Hello everyone and welcome to the July 2024 Medic Monthly video. The topics in this video are going to be cardiac related, specifically a lot of cardiac arrest stuff. We have Master Firefighter Greer, who's going to be talking about out of hospital cardiac arrest. We have Firefighter Cook, who's going to be going over the new VFib and VTAC protocol, as well as the dual sequential defibrillation changes. We have Captain Brown, who's going to be giving us some tips and tricks for how to manage our ROSC patients better. I'm going to go over hypotension, vasopressors, and the new Levophed update. And Lieutenant Tipton is going to go over an update to the Sapphire IV pumps. Real quickly before we get into the topics for this month's video, I'm going to add these 3 QR codes to the end of every monthly video going forward. The reason for that is I've been getting a lot of good text messages and emails and phone calls with ideas for EMS training or ideas for monthly video segments. And I want all of those, and please keep sending them in, but I was losing them in my inbox, my text messages, forgetting about them from phone calls. So to make it simpler, if you have an idea for EMS training or a monthly video segment that you want, scan the QR code on the left and send it in. If you have general feedback on good or bad, how we could put out better content, scan the middle and let me know. And if you're interested in getting involved with teaching, scan the one on the right and I'll get in contact with you about that.
Hello, this presentation will focus on disabling our Sapphire IV pump air detection systems. I'm Will Tipton, the Quality Improvement Process Owner for MCFRS's IV pump program. I'm here to talk about the decision to disable the air detection systems on our Sapphire IV pumps and its implications for the safety of our patients. Since implementing our IV pump program last year, EMIHS has recognized the concerns of our clinicians that there are too many air detection alarms. Additionally, after conversations with the manufacturer, we believe that rapid infusions, such as those we use with lactated ringers, and hypertonic solutions like D10, may lead to excess alarms. The air bubbles that are detected during these infusions are almost never clinically significant. The result of this is inappropriately interrupted therapy for our patients and frustration for our clinicians. We recognize that this process has been exasperating for our personnel. After careful consideration, we have come to the decision to disable the air detection systems on all of our Sapphire IV pumps. This is necessary because the pump programming does not allow for alarms to be disabled for specific medications. After we have disabled the air alarms, you will see the icon to the right constantly displaying on the top of the screen, and you will have to acknowledge a warning before beginning an infusion. It is imperative to emphasize that we need to be even more vigilant when setting up infusions and flushing our tubing to ensure any excess air is removed. So, before beginning an infusion, you must acknowledge the warning shown here. MCFRS does not carry filtered IV infusion sets, as these can inactivate some of our medications, including nitroglycerin. Additionally, only very large volumes of air have been shown to be fatal or harmful to patients, and a filtered set would not prevent these complications. Finally, it is essential to recognize that an empty IV infusion system under pressure from a pump does pose more of a threat of infusing greater volumes of air than a gravity infusion. These are important actions due to the disabling of the air detection systems. The first is a repeated reminder to use extra vigilance when setting up and flushing tubing to begin an infusion. This includes burping the bag to remove excess air and manually priming the tubing. The medication bag must always be hung upright when delivering an infusion. Vigilant monitoring of the medication reservoir must be maintained at all times, and if the bag is almost empty, you should stop the infusion. In some cases, you may need to connect an additional bag to complete the dose of medication. If you ever believe a patient received an infusion of air or displays signs and symptoms of an air embolism as listed on the slide, the patient should be placed in the left lateral Trendelenburg position and given 100% oxygen via a downward breather mask. Thank you for your attention. If you have any questions about this topic or anything related to our IV pump program, please reach out to me via email. Have a great day and stay safe.
Hello, my name is Justin Greer, and I'm a Master Firefighter Paramedic at Station 8 on C Shift. The topic I will be discussing with you today is out-of-hospital cardiac arrest. As an organization, Montgomery County Fire and Rescue is doing an amazing job at managing patients who experience out-of-hospital cardiac arrest. MCFRS runs almost 800 cardiac arrest events per year. Approximately 250 to 300 of all patients we encounter in cardiac arrest get return of spontaneous circulation. That's roughly 1/3 of all cardiac arrest patients we see get ROSC. What's even more amazing is about 40 to 50 people per year walk out of the hospital neurologically intact because of our department's excellent work. So you may be asking yourself, if we're doing such an amazing job at managing patients in cardiac arrest, why do we need to talk about it and why this video? The answer is simple. We think that we can do even better than what we are doing right now. What does better look like? Better is more people walking out of the hospital neurologically intact. Our goal is to close the gap between the patients in whom we only get a ROSC and either lose it or they die in the hospital, and those who walk out of the hospital neurologically intact. How do we begin to close the gap between ROSC and neurologically intact? The first step is running an efficient cardiac arrest. We will take a look at what a model cardiac arrest looks like using the IRP Appendix U, Management of Cardiac Arrest, and the spasm mnemonic as guidelines for our demonstration. Then we will be discussing current best practices for minimizing interruptions in chest compressions. To conclude our conversation, we will talk about the roles LUCAS and POCUS in the context of out-of-hospital cardiac arrest. As a quick reminder, there are three main takeaways from the IRP Appendix U. Number one, high-quality chest compressions and early defibrillation are our top priorities. 2, ALS interventions are a lower priority. 3, pre-response planning, including designation of a CPR boss, a runner, and a clinical decision maker, are important first steps to success. Let's start before the call even gets dispatched. In the morning, at lineup, a brief discussion should be had about who's going to be filling what roles. The IRP does not state that you are limited to the roles outlined in the policy. It just states that there are a few key positions that need to be filled. However, experience has shown me that there are other critical roles that need to be filled in addition to those outlined in the IRP. It is my opinion that the ALS clinician is looked to, regardless of rank, to help guide the crew resource management. Before the cardiac arrest, the ALS clinician communicates with the members of the crew so that each member knows what their responsibility is prior to arriving at the site of the patient. On a 4-person paramedic engine company, a typical lineup would look something like this. E1, the driver, could be the CPR boss. E2, the officer, will be a scene manager. E3, the BLS clinician, will be the runner/BLS airway. E4, the ALS clinician, will be the clinical decision maker / second ALS, BLS, airway, depending on the number of people available. If you're riding a medic unit, M1, the medic unit driver, will be responsible for BLS airway, chest compressions, and bringing equipment to the patient. M2, the ALS clinician, could possibly be the clinical decision maker. They may fill the role of second ALS and be doing BLS airway depending on the number of people. If you're riding on a chase car, depending on the arrival order, the medic off the chase car could be used as a runner, clinical decision maker, or second ALS. Now that we know everyone's role, we will take a minute to discuss what each of these roles entails. CPR boss. They run hand heavy, keep track of time, count down time until pulse check, particularly 15 seconds out. More on that later. Also, they keep track of time during pulse check so that the time does not exceed 10 seconds. Scene manager gathers patient information and talks to the family. They ensure the safety of the crew on scene and communicate additional needs to ECC and coordinate resources. Runner, they get to the patient quickly as possible and confirms the code and begin chest compressions. The clinical decision maker is responsible for analyzing the rhythm at pulse checks, delivering appropriate electrical therapy and medication selection, and administration. Second ALS, they are responsible for establishing IO/IV access as needed, ALS interventions, and assisting with medication administration as needed. Compressors, providers that are available are to be rotated through chest compressions. We should take a moment to talk about establishing a floor of care. What does that mean? A floor of care is simply the most basic elements of caring for a patient in cardiac arrest. These elements are put together in such a way that there is a solid footing for all other care to be built off of. Just like when you're building a house, if you don't have a solid floor, then you don't have solid walls. And if you don't have solid walls, you don't have a stable roof, and then the whole thing tumbles down. So here we build a solid foundation of BLS skills so that our ALS interventions have something to stand on and can actually improve patient outcomes. We build our floor of care using the spasm mnemonic. The first step is stopping. This means that we stop moving the patient if we're in the process of moving them, or move the patient only as much as necessary to facilitate working the code and ensuring crew safety. This also includes stopping the transport unit if the patient is being transported when they code. The transport unit should be stopped in such a manner as to ensure crew safety. Next is pressing. Pressing is all about high quality chest compressions delivered at the appropriate rate and depth for the patient being taken care of. The runner starts compressions. Next, applying pads. This should be done by the clinical decision maker as early as possible, working around the runner doing compressions. After the pads are on the patient, the clinical decision maker should power on the monitor and then use the lead button to select paddles. This ensures that CodeStat can capture the data on the code. Finally, the clinical decision maker should turn on the metronome built into the monitor to ensure that compressions are being performed at the appropriate rate. Now let's take a look at what the first few minutes of a cardiac arrest resuscitation should look like when the IRP and spasm are applied.
Hey, it looks like he just lost his pulse. When we get to the top of the steps here, we're going to stop and you can check for a pulse, okay?
Okay. I don't have a pulse.
All right, start CPR. I'm going to go grab the bags. Medic 708 Montgomery, go ahead and stop me in AFRA. We have a working code. I'm going to take over compressions for you here in a second. I'm going to get the monitor on. And then after I take over compressions, you're going to get some BLS airways going and start bagging this patient, okay?
Okay.
All right, go ahead and stop compressions. All right, patients in PEA, go ahead and get the BLS airway going. All right, if you want to switch in 10 seconds, 10, 9, 8, 7.
What have you guys done and what do you need?
Hey, Lieutenant, can you go check with the family to see if this patient has any medical history? And whoever's going to be the CPR boss, can you get Hand Heavy up and running?
Hand Heavy's going. Okay, we're 15 seconds out. Go ahead and charge the monitor. 3, 2, 1. Pulse check. Check rhythm. Go ahead and prepare the back plate under the patient.
All right, Oscar, back on chest.
Okay, 15 seconds out from a pulse check. Charge the monitor. Pulse check in 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Pulse check. Check for rhythm. Prepare to swing the Lucas over and lock it in over the patient.
Have PEA on the monitor. Continue CPR.
Hey guys, what do you have? Hey, we have a patient that's been in PEA the entire time with no palpable pulses, radial or carotid or femoral. So if you have your POCUS, we could take a look and see what's going on.
Perfect. I'll go and get that started. How much time for the next pulse check?
We have a minute and 30 seconds to the next pulse check.
Turn to the left here.
All right, patient's still in PEA.
Okay, I have signs of circulation.
All right, perfect.
Now that we have taken a look at what a cardiac arrest scenario can look like when the IRP, spasm, and current best practices are applied, let's take a moment to break down what we saw right before the pulse checks and during the pulse checks. A successful pulse check should be no more than 10 seconds. Added up over the course of a 30-minute resuscitation, if pulse checks are kept at 10 seconds, each patient still experiences 140 seconds or 2 minutes and 20 seconds of no compressions. Additionally, after each break, it takes time to regain sufficient blood pressure to begin circulation and perfusion of the heart muscle, organs, and brain. So every effort must be made to minimize breaks in compressions. The elements of a successful pulse check are: number 1, pre-charging the monitor 15 seconds out from the pulse check. 2, having hands on pulse points during compressions, so absence or presence of pulse can be felt rapidly during the pause in compressions. 3, rapidly interpreting the rhythm. 4, having the monitor close to the clinical decision maker so that they can administer the appropriate electrical therapy or dump the charge. 5, communicating and being smooth with the operation of the Lucas device. 6, communicating with the EMS duty officer about the use of POCUS during pulse checks. The Lucas device is a very handy device in terms of saving effort during a code. However, every effort must be made to minimize the time that it takes to apply it. It is most efficiently applied in 3 distinct steps. Number 1, placing the backplate under the patient at the appropriate pulse check. 2, turning on the Lucas and locking one side of the Lucas in place during a cycle of compressions. 3, locking the other side of the Lucas and lowering the plunger so that compressions can begin as needed at the end of the pulse check. 4, consider using the neck strap to prevent the Lucas from sliding down the patient. Point of care ultrasound, or POCUS, has been a recent addition to our toolbox for the management of our patients in cardiac arrest. It is carried by the EMS duty officers only and can be used in patients that are experiencing PEA. The reason for this is the PEA we are seeing on the monitor may actually be a pseudo-PEA. This means that the patient has an organized cardiac rhythm that is actually moving blood around their body, but is doing so with insufficient pressure to generate a palpable pulse. The POCUS is able to identify blood flow in the carotid arteries in the absence of a palpable carotid pulse. As will be discussed in this video, additional care should be provided to the patients experiencing a pseudo-PEA. In summary, remember to use the IRP to establish roles and responsibilities before the cardiac arrest gets dispatched. Use the spasm mnemonic to establish a floor of care so that our ALS interventions have a foundation to build off of. Also, every effort should be made to keep our pulse checks under 10 seconds. Keys to success include pre-charging the monitor, feeling for a pulse prior to the pause, rapidly interpreting the rhythm, having the monitor close at hand and minimizing the interruptions, of applying Lucas and using POCUS. Finally, don't forget to document. Remember, if you don't document, it didn't happen, or so I've heard. This includes POCUS. The ALS clinician writing the report must document POCUS for the EMS duty officer. Thank you for all that you do. Remember that what we are doing is making a difference, and with some effort, and the honing of our cardiac arrest practices, we can hopefully do even better.
Welcome to your next video of the July 2024 ALS Professional Development CE videos. My name is Joshua Cook. I'm at Station 8 on the C shift, and today I'll be presenting on the new ventricular fibrillation and pulseless VTach algorithm that is in the protocols. So as you already know, the ventricular fibrillation pulseless ventricular tachycardia protocol changed in this year's protocols, and we're going to be covering that and how it applies to Montgomery County specifically, and you should already know a bunch of this having done your protocol update that involves this. So what are we talking about today? We're going to be talking about what is this new protocol, why is it being implemented, and why are there changes to medication dosing regimens and defibrillation techniques, and what is this drug Esmolol and how is it used? So if you've been around for a little bit, you know that the cardiac arrest algorithms have come and gone and changed, and we've seen many different things over the years. Over the past 5 to 10 years, we've seen some very significant changes in how we run these cardiac arrests, going from doing hands-only or manual compressions and figuring out ways to get to the unit and moving on and getting to the hospital as quick as possible, to working them on scene, to involving termination of resuscitation, and some changes in our defibrillation techniques and the medications that we're giving. This new protocol will be a drastic change from how we've practiced in the past, especially with patients presenting with VFib or pulseless VTAC. And don't worry, there will still be pieces from the past. This is not a complete change. So let's talk about what we've been doing in the past, especially within the past year or two. When having a patient that has VFib or pulseless VTAC, they've received the following: standard defibrillation with a vector change after the third shock, bag valve mask ventilations, chest compressions, epi 1 to 10,000 IV every 4 minutes to a max of 4 administrations, amiodarone 300 milligrams IV, an additional 150 milligrams IV as needed, and any other appropriate medications procedures as indicated. Many pieces of this will still be present in the new protocol, but there will be some changes. So, on to the new ventricular fibrillation pulseless VTAC algorithm. So as always, we're going to start high performance CPR and provide adequate oxygenation and ventilation. Our first defibrillation is going to be at 200 joules and it's going to be a traditional pad placement. So one on the left flank and one over the right shoulder. Immediately resume CPR after 2 minutes, just like we've been doing all along. Upon assessment of the rhythm after 2 minutes, if we find VFib or pulseless VTAC again, we're going to defib at 300 joules, get right back on the chest, continue with CPR. We're going to establish IV or IO access, depending on what works best for this patient. If you have the resources available, this can be performed during those initial 4 minutes of CPR during those 2 defibs. This does not have to come after your second defibrillation. Once you have IO or IV access, we're going to first administer 300 milligrams of amiodarone fast push. This is a big change from what we've always done before. Amiodarone came a little bit later in the algorithm in the past, but we're going to do this first, and we'll explain why later. We're going to immediately follow up with a single dose of epinephrine, 1 milligram. This is the only time we're going to give it unless we have ROSC and re-arrest, where we will give another single dose of 1 milligram of epi. Upon assessment of the rhythm after 2 minutes, if we find VFib or pulseless VTAC, we're going to defibrillate again at 360 and immediately resume CPR. So at this time, we're going to take some steps to set up our alternative defibrillation techniques, either vector change or double sequential external defibrillation, or DSED. We in Montgomery County will primarily be using double sequential, but if resources determine that you can only do vector change at the time, aka you only have one monitor with you, then you start with vector change. Once the second monitor shows up, that is when we will switch to double sequential pad placement and initiate all further defibrillations via double sequential. So using double sequential, we're going to defibrillate one more time at 360 from each monitor and immediately resume CPR. Then we're going to administer amiodarone 150 milligrams over 2 minutes. If we, at the next 2 minute point, we find VFib and pulseless VTAC again, we're going to go again with 360 joules from both monitors. After that, so this is our 5th shock total, or our 5th set of shocks, our second DSED, we're going to administer Esmolol 500 micrograms per kilogram over 1 to 2 minutes. After that point, we're going to repeat CPR and defib until either ROSC or termination is determined, and then transport. The medications of mag sulfate will be indicated for any torsades. And then in case of hyperkalemia, we're going to want to give calcium chloride. And any sodium channel toxicity suspected, we want to give sodium bicarb, 1 MEQ per kilogram. So part of this algorithm talks about this thing called eCPR, or extracorporeal CPR. The majority of cardiac arrests in Montgomery County will not be involved in this final piece of the algorithm based solely because we are not close enough to an ECPR capable facility. The only ECPR capable facility close to Montgomery County is MedStar Washington Hospital Center, and it is not close enough. So just a real quick rundown why ECMO capable does not equal ECPR capable. Many hospitals in Montgomery County are capable of doing ECMO within their ICU, but they are not able to do ECPR. ECPR requires a team of highly trained specialists and doctors to be available 24/7, 365 on site, not on call. This is a great disqualifier because of the massive amount of coordination and training needed for these teams. So now to cover why some of these changes were made in the new algorithm. There's numerous studies that point towards some major contributing factors to survival from VFib or pulsus VTAC. VFib reoccurrence within 2 minutes can be as high as 48% and 78% at some point during pre-hospital care. So we want to do everything we can to change this VFib. So when we shock these patients and we are immediately going back on the chest, they are going back into VFib. They are not, it's within 2 minutes and then, or at some point during the arrest. And then we've also found that alternative defibrillation techniques and medication dosing changes have shown to increase favorable neurological outcomes. That's what we're really shooting for, is the favorable neurologic outcomes. So, pad placement and double sequential and vector change. This comes from the DOSE-VF trial by Cheskis et al. It's out of Canada. This is what influenced our change in Montgomery County to vector change last year. In this study, they found that the termination of VFib into a perfusing rhythm was 67.6% in traditional pad placement, 79.9% in the vector change, and then a whopping 84% in double sequential. So this double sequential pad placement and defibrillation resulted in the most amount of termination of VFib, and then in turn, favorable neurological outcomes. So when you're doing vector change pad placement, we're going to be having done 3 shocks with our standard pads, and we're going to be placing our posterior pad and replacing our side pad. So when it comes time to do our rhythm check, we're going to get our pads out. We're going to be using the sternum pad, the pad that has this pad icon on it. Okay, we're going to pause compressions, and we're going to roll or move the patient in a way that we can access the back. And we're going to place our Lucas backboard, and we're going to get back on the chest and continue compressions. We're going to remove this pad from our standard pads and place our new vector change pad on the side. We're going to analyze, and we're going to shock. Okay, cool. So here in Montgomery County, our alternative defibrillation technique of choice is going to be double sequential. And now we're going to go over the pad placement for that defibrillation technique. So we have our standard pads in place because we've done our 3 standard shocks ahead of time, or already. And now we're going to place our second set of pads from our second monitor. We're going to pause compressions, and we're going to place our sternum pad on the back. Pause compressions, roll, place the pad, place the Lucas backboard, and back on the chest while we prepare to place our anterior pad. Pause compressions, place the anterior pad, and continue with manual compressions. Now what we're going to do is we're going to charge up both monitors. And now we're going to charge up both monitors to 360 joules. And with the same thumb and the same provider, you're going to hit one and the next, hopefully under 1 second. And that's it. And continue compressions after that. Okay, so there were some changes to the medications, as was quite obvious in the algorithm that we showed before. So with Epi, so the studies have found that Epi does increase ROSC, but unfortunately a large amount of severe negative neurologic outcomes. So while we are driving, getting a perfusing rhythm back, they are not being successfully discharged from the hospital with neurologic outcomes. And that's ultimately what we're shooting for. There is some questionable use in shockable rhythms and potentially increases the chance of arrhythmias. But overall, this is what changed our mind to decreasing the amount of epi that we're giving. The dosing is going to be 1 milligram of 1 to 10,000 IVIO once, immediately following your amiodarone. So, changes to amiodarone. Not so much changes, but when we're giving it. It's not the dosing, but it's when it's given. So there are no large-scale studies that focus on amiodarone in the presence of refractory VFib or VTAC. But the theory behind administration early is that it should aid in early termination of shockable rhythms and prevent from the reoccurrence. So essentially, it's going to prime the heart to accept defibrillations better in the chance of terminating this VFib or pulseless VTAC. The dosing, as it's always been, is going to be 300 milligrams IV or IO after your second standard defibrillation shot. So you're looking at this in your first 4 to 6 minutes. Then an additional 150 over 2 minutes following your first vector change. So remember, this is going to be your first med, not epi, as it's been in the past. Okay, so this addition of this new medication, Esmolol. A quick little background on it. As you should be able to tell from the name, because it's a LOL drug, it is a beta blocker, and it primarily targets the beta-1 receptor. It acts primarily on chronotropy, so the rate at which the heart beats, and has minimal effects in inotropy, which is the pressure behind it. There are no specific studies on its use in refractory VFib or pulseless VTAC, but there is a growing body of evidence of its efficacy, meaning that no one has actually studied it specifically, but they have seen it used in algorithms and know that the evidence behind it shows that there are some good outcomes. Basically being increased ROS rate and increased positive neurologic outcomes. The theory is that there is a need for beta blockade to mitigate the sympathetic catecholamine surge resulting from the myocardial ischemia brought on as a result of pulseless or of VFib and pulseless VTAC. The dosing is going to be 500 micrograms per kilogram over 1 to 2 minutes, and it will be coming in vial form, and it will be a push med, not through the pump. Thanks for watching. Hopefully this clarifies some of what was covered in the protocol update and what you may have been hearing at the kitchen table or from your duty officers. But any questions, please direct them to your respective EMS duty officer or the EMIHS office. And thank you for your time and attention.
Hello, my name is Captain Brown. I'm EMS 704 on C shift. Welcome to July's ALS Continuing Education module for ALS providers. We will focus on the post-ROS care bundle in order to prevent our patients from rearresting and to better stabilize them prior to transport to the hospital. You perform a pulse check and the pulse is palpable. Now what do? First, place the Lucas in standby to quickly facilitate a restart of compressions if needed. In the past, we've quickly began packaging our patients and moving towards how to move the patient and get them out and into the back of the unit where we can continue care. Our practice has changed. Studies have shown that this is the most critical time for the patient and worth the while to pause and slow things down. It's time to find out how to best stabilize our patient by assessing, correcting, and or maintaining what we have accomplished until the patient can get to more definitive care. The goals of our post-cardiac arrest checklist is to increase hemodynamic stability and decrease intra-transport rearrest. Let's get back to the basics. ABCs. Let's start with the airway. Check what you have in place. If the patient is intubated, check the position of the tube, ensuring that it is the same location as when you initially intubated. For example, at the teeth or the lip. Confirm your vital signs. if you have a supraglottic airway in place, is it still providing adequate ventilation? Did you place the oral gastric tube through the supraglottic airway device? Could the patient benefit from a more secure airway if you have not attempted an intubation? Or if you were maintaining the patient's airway without the use of devices such as an airway adjunct, high flow nasal cannula, and BVM, now would be a great time to do an intubation. The next step is to assess how well we are breathing for the patient. We should only be providing an average of 350 to 450 cc's for the average adult patient. This should be just enough to make the chest rise. We want to ventilate 5 to 10 cc's per kilo roughly, based on lean body mass. The average adult, again, is 350 to 450 cc's, which is only about a quarter to 1/3 of the BVM bag. While we want to give maximum oxygenation during resuscitative efforts, the goal in post-arrest is to keep the oxygen saturation at or above 94%. We want to do our best to avoid over-oxygenation. So to do that, we want to consider altering ventilatory rates. Standard ventilatory rates should be between 10 and 12 breaths per minute. That's the standard. We want to ventilate between 8 to 10 breaths per minute for COPD and asthmatic patients. We want to consider 12 to 14 breaths per minute for an end-tidal CO2 of greater than 45. Our end-tidal CO2 monitoring should target 30 to 40, thus giving us a PCO2 between 30 and 45 in the bloodstream. For our pulse ox, again, we discussed 94%. Our target SpO2 is ideally between 88 and 92% for our COPD patients. We can titrate the O2 down. We also want to make sure that we have a standardized PEEP of 5 centimeters of water. Consider 10 centimeters of water for your CHF patient. Moving on to our circulation, we need to assess the patient's rhythm on the monitor and determine if the rhythm is conducive to adequate perfusion for the patient. And do we need to do anything to help it best perfuse the patient? Apply the 3-lead and obtain a 12-lead EKG. So let's take a look at our rhythms. If the patient is in SVT, we want to wait 5 minutes to cardiovert the patient to allow the heart to become less irritable, reducing the risk that we may put the patient back into cardiac arrest. However, if it's a Y complex tachycardia, we want to cardiovert the patient immediately, as we know that this can be a lethal rhythm. Consider an amiodarone infusion. Since we have a pulse, we should do the infusion at this time. If the rhythm is okay, but we are still not achieving the blood pressure we desire, which we would like to be between 90 and 110 systolic, a MAP of 65 or greater, then we want to give a fluid bolus and consider vasopressors to help us achieve the desired range. This will be a great time to start a second intravenous access, making it easier to facilitate our fluid bolus and the administration of our vasopressors at the same time. While we are still in place, let's revisit that 12-lead EKG that we wanted to obtain. Up to 30% of ROSC patients will have a ST elevation myocardial infarction. This allows us to transmit early and facilitate the early activation of the STEMI alert at the receiving cardiac intervention facility so that they are ready upon our arrival to potentially decrease the time to get the patient to the cath lab. We want to repeat the EKG again just prior to transport. In the post-arrest care, we also want to ensure at this time to check a glucose and correct any issues that we may be concerned with. Lastly, we want to maintain a neutral temperature for the patient. We don't want to do any rewarming of the patient, although we do not want to begin any cooling measures as this is difficult for us to sustain. Thank you for taking the time to review the post-arrest checklist with me. It is my hope that you understand the procedure that we would like to utilize with our post-cardiac arrest patients in order to better stabilize them, giving them the best opportunity for success.
Hello everyone, welcome to the hypotension portion of the research. We're going to be going over the different types of medications we use to treat hypotension, especially one of the new ones, meaning Levophed. And then we're also going to go over the different disease processes that might lead to hypotension and what medications are better or worse for certain diseases. So let's go ahead and get into it. The topics we're going to cover in this PowerPoint are the different types of hypotension and shock states, the medications used to treat hypotension, and then specifically we're going to talk about hemorrhagic shock and the do's and don'ts for treating hemorrhagic shock in the field. Starting off with the common types of hypotension. I find it easiest to break it down into a volume problem, a container problem, or a pump problem. On the right side, we have a graphic that goes a little bit into the subcategories, uses medical terminology, gives you a little greater detail on the different categories of shock, and you're more than welcome to look at that if you like. But we're going to stick with those three on the left side for this presentation. A volume problem is just that. You have 6 liters of blood in the container normally, that's what you need to function. You now have 3 liters and you lost it through either bleeding or you lost it through a disease process, and that's going to cause your hypotension. A container problem, like neurogenic shock, is something where you have the 5 or 6 liters of blood in the container, you're good to go there, but through a disease process or trauma or whatever it may be, your container dilated and is now, let's say, 8 liters, and that's going to cause hypotension. Finally, we have a pump problem. This can be either a bradycardic issue where the heart's not squeezing fast enough to deliver the blood to the end organ, or a cardiogenic shock where the squeeze isn't hard enough to deliver that blood to the end organs. So what medications do we carry to treat hypotension? We have EpiDrips, which is our primary pressor of choice currently. Ever since we gave up dopamine, we adopted EpiDrips. We run those in the pump now, so we don't have to eyeball the 1 drop per second anymore. We have lactated ringers, which is our crystalloid isotonic fluid of choice here in Montgomery County. We have norepinephrine or Levophed, which is the new medication that was added in July 1st of 2024. There's going to be more direction coming out about that, and we're going to cover that medication in depth in this video. And then finally, we're going to talk about dopamine. Even though it's no longer carried on our units, it is still in the Maryland State Medical Protocol. So if we're going to talk about hypotension and shock states and pressor agents, we should at least review dopamine. So looking at epinephrine drips, what does Epi do when you give it to a patient? We all know the first thing you see is that the patient's heart rate increases, and it can be a pretty dramatic increase. Epinephrine does a good job at that. It also does a good job of increasing cardiac contractility, or how hard the heart squeezes. So if you need either of those effects, an increase in heart rate or an increase in cardiac contractility, epinephrine might still be your medication of choice. It can cause cardiac ectopy, PVCs, PJCs, runs of VTAC, especially in patients who are predisposed to having cardiac rhythm disturbances. So do be careful when giving epinephrine that you monitor the patient's EKG. It is not the best medication for vasoconstriction. Does it cause vasoconstriction? Absolutely. But now that we have Levophed in the toolbox, it is not the primary or the best medication to cause vasoconstriction. So looking at the bottom left for our 3 simplified types of shock, if you have a container problem, it has minimal effect. We know that it's not the best medication for vasoconstriction. It will cause some, it will help a little, but it's not the best anymore. If you have a pump problem, it's very effective. We know when we're talking about pump problems, we're talking about the patient being bradycardic, or you're having a cardiogenic shock where your heart isn't squeezing hard enough. And epinephrine does a great job at fixing those 2 problems. Now for volume, it's not indicated until proper fluid or blood resuscitation has been given. And we're going to talk a little bit more about that in the hemorrhagic shock portion. On the right side, we have the protocol for epinephrine infusions. Go ahead and pause the video and read over that if you like, and we'll move on to the next medicine. Moving on to norepinephrine, or Levophed. This medication was added July 1st of 2024 to the Maryland State Medical Protocol, and it came in as an optional supplemental protocol. So if you're trying to find it in the manual, it's all the way at the back. Montgomery County decided to opt into that, and we're going to start carrying the pre-mixed norepinephrine bags, 4 milligrams and 250 milliliters, very shortly. If you read the protocol, it does talk about either mixing it yourself or the pre-mixed bags, and we're deciding to go with the pre-mixed medication bags here in Montgomery County. What does norepinephrine do? So very simply, it is a pressor agent that causes significant vasoconstriction. It does an excellent job at causing that container to shrink down, tighten up. So when you think about a container problem where that is the issue we're having, is that the vasodilation is causing hypotension, norepinephrine is the best medication to treat that type of issue. When you look at pump problems, an issue with the heart rate or the heart squeeze, it's going to have minimal effect. Just like epinephrine has some effect on vasoconstriction, but not the best, norepinephrine does have some effect on heart rate and cardiac squeeze. It will make those increase, but not as much as something like epinephrine. Finally, there is less likelihood of cardiac ectopy with norepinephrine. You still should have these patients on 3 leads, obviously, monitor their heart rate, but less likelihood of PVCs, PJCs, runs of VTAC, stuff like that. I'm not going to talk about dosing in this presentation because our EMS leadership is still trying to figure out exactly how we're going to work with our pumps and with these new premixed medication bags. So be aware that there's going to be more direction coming on exact dosing and the protocol we're going to follow in Montgomery County very shortly. Moving on to LR. No need to spend a whole bunch of time on this one. We've all given plenty of LR. But what does it do? It's a crystalloid isotonic fluid, which in simple terms means it's a small molecule that does not cause fluid shift in or out of the vascular space. It does not carry oxygen, and it does not stay in the veins for very long. Actually, the body moves that fluid from the vascular space to other spaces in the body or excretes it very quickly. So if you want to keep that patient's blood pressure up, you're going to have to keep giving boluses of LR. Otherwise, you're going to see that patient become hypotensive again. So when we look at our 3 types of shock, it is effective in a pump problem and a container problem when paired with the appropriate vasopressor. So in terms of a pump problem, we know that epinephrine does a good job. And in terms of a container problem, we know norepinephrine shrinks that container down very well. So we're going to give our lactated ringers in small 250 cc boluses along with the pressor of choice for that specific problem. Moving on to a volume problem, it is excellent when the patient is volume depleted. What I mean by that is I think lactated ringers is kind of following the same path that oxygen followed for BLS providers, in that we used to give oxygen to everybody, and now we only give it when the patient meets a certain criteria. For paramedics, I think lactated ringers is in that same vein. We used to give it to everybody, and now we're assessing our patient fully and going, does this patient actually need LR? Will they benefit from a bolus of LR, or is that not the problem? So for volume, it is absolutely indicated when they need it, when they're volume depleted. On the top right is the protocol for you to review, and we'll move on. Finally, we have dopamine. Dopamine is a very dose-dependent medication, which is where you get that 2 to 20 microgram range from the protocol. So in pre-hospital medicine, what we're looking for is more of a one-size-fits-all, set-it-and-forget-it type of medication. What you get with dopamine is something that you have to titrate quite a bit to get the desired effects from, which is why it's kind of fallen out of style, and we've picked up things like epinephrine and norepinephrine to replace it. Dopamine also has a higher rate of tachyarrhythmias and an increased mortality in septic shock when compared to other pressor agents like Levophed. So when's the best time to use it? In a zombie apocalypse. When you have nothing else, dopamine might be beneficial, but in the pre-hospital setting, these days we have better medications to use in the treatment of hypotension. At the top right is your protocol if you'd like to pause and review it. Moving on to hemorrhagic shock. When treating a hemorrhagic shock patient, we have to ask ourselves, what is the goal? And the goal is essentially to maintain end organ perfusion, to get them the blood, to promote clotting, and to keep them warm. How do we accomplish this? Well, for end organ perfusion, you give small 250 ml boluses, just enough to maintain perfusion to their brain and their kidneys. We get them the blood as quickly as possible, whether that be the hospital or we know that blood is coming to the field in duty officer cars, so get them to the closest duty officer or have them come to you. Super, super important to get these patients' blood products as quickly as possible. We want to promote clotting, and we do this 2 ways. 1, by not drowning them in LR, and 2, by giving a medication like TXA if indicated. Finally, we keep the patient warm. From the second we get to the scene to the second we drop them off, we want to make sure we're keeping that patient nice and warm. If you keep these 4 points in mind, you're going to be in a pretty good spot when taking care of your hemorrhagic shock patients. So to summarize, once norepinephrine shows up, here is how we're going to pick the appropriate medication for the appropriate disease process. For EpiDrips, it is our frontline medication for all anaphylactic shock, for all bradycardic issues after TCP or if TCP has failed, and it's still going to be our medication for pediatrics because the norepi protocol only applies to adult patients. Moving on to norepi, it's going to be for neurogenic, for septic, for vasoconstriction. It's a great I don't know pressor. It's going to be our frontline pressor for almost everything that isn't anaphylactic shock, bradycardia, and pediatrics. Lactated ringers is excellent when paired with other pressors or when the patient's disease process indicates that they need boluses of LR. Something like DKA or HHS where you know that patient's volume depleted, LR is still your best bet. Finally, we have dopamine, dose-dependent medication, not very effective in the pre-hospital setting. We have better medications now in the medic unit, and hopefully we don't have to use it. A couple of scenarios to finish up. Starting with a bradycardic patient in cardiogenic shock, you try to pace, but the pacer is unable to capture, so you have to give a medication. What medication are you going to give to treat this bradycardic shock? Hopefully you said EpiDrip. We know that epinephrine has the most effect on heart squeeze and heart rate, so in this case, an EpiDrip would be the best option. Moving on to a septic shock from skilled nursing. Hopefully you said Levophed or norepinephrine. We know that Levophed is going to do an excellent job of vasoconstriction, and it's not going to be too hard on that patient's heart. Finally, we have a patient with multiple stab wounds, puddles of blood on the ground. How are we going to treat them? Hopefully you remember the last slide and said, I'm going to get them the blood products, I'm going to keep them warm, I'm going to promote clotting, and I'm going to maintain end organ perfusion with small boluses of LR, just enough to maintain perfusion to the brain and the kidneys. So now that we have 2 vasopressor agents on our medic units, just be aware that you're going to get there and have to stop and think for a second. What is actually causing the hypotension? Is it a pump problem, a container problem, or a volume problem? And then treat accordingly with whatever medication you pick. Be on the lookout for the CPG and dosing direction to come out shortly. And let me know if you have any questions. Thank you very much for watching this section of the video. Thank you so much for watching the July 2024 Medic Monthly video. I hope you learned something. If you have any suggestions, comments, questions, please scan that QR code from the beginning of the video and send them in to me. I would love to hear it. Thank you so much.